Thank you for tuning in to Out of the FHIR podcast, where we talk about FHIR interoperability, data, and anything else. This week, we're continuing our conversation with Brendan Keeler and Jason of Fasten Health.
I think that's like, you see that similar take with like Apple Health, where I go in and I look at my data and it's like, I know they're not doing anything with it, or they're doing like the minimum necessary and they're trying to best manage that data. But even like raw data, how do you best display it to the patient? There's many different takes on that, but I feel like the first step is obviously just make the connection, because that in and of itself is an extremely difficult process in healthcare. So yeah, so you do agree, Jason, that that's like a value add, and it sounds like Fasten is doing that, which is great to hear. I think that ultimately we also have to think about interoperability is not the end goal in and of itself, though many people will say it is the end goal, but like the patient improving outcomes and getting access to their care and having more cost-effective and actionable healthcare is the goal, right? So how do we get to that? It's just data to insights. Do we then start thinking about exchanging? We've seen a lot of effort from CQA and CMS on quality measures and actual insights for patients. And that's one of the things that like I loved when I was at BOLs, because we had a patient-facing, kudos to all the folks there working on that patient-specific, patient-facing platform for insights, where it's not just your data. You don't have to try to figure it out yourself. We will tell you when your next visit needs to happen, what you need to do to better manage your condition. Do you feel like that's a big part of this Plaid ultimate value add service for all these different jobs to be done, to have access to not just the data, but the insights?
So like, just personally, I feel like data out of context is kind of like a form of navel gazing. Like as a patient, there's really not a lot. There's not a lot that a patient that doesn't have a medical background can necessarily do with just the raw information. And that's primarily because if you look at the data that you're getting through these pipes, you're actually going to see record information that's really intended to be used by building systems, that's intended to be used by other practitioners. It's not written with the patient intent in mind, right? And so when you have to, if you want this data to be valuable to the patient, you have to do some sort of parsing of the data, some sort of synthesis of meaning from it and translation effectively to something that a patient could actually understand. And that's not to say that there aren't patients that are also, have a very acute understanding of their medical data and the details of it. But at the same time, I think for a majority of individuals, it's not useful. It requires these insights. Now, does it make sense for a platform like Plaid, like Fasten to try to do all the things? I mean, I'm going to just straight up say that I don't think we can, right? I don't think that's where we provide the most value. It's not an area that I think makes sense for us to kind of tackle head on right now. But like I said, I think when we can see a broad consensus across our customers that, hey, there's certain fundamental understandings they want to get from the data that we're pulling, certain enrichments and things like that we can do as we're parsing the data and collecting it on behalf of these organizations and customers, I think that makes sense. But trying to glean insights for patients, I don't know if that's a good fit for us. I think one of the other things to kind of keep in mind is, again, ignoring TEFCA, right? If you're just looking at it from the point of view of a patient access API, every connection, every link to a health system and a healthcare organization is done in. So Jason, or let's say John Doe at New York Presbyterian Hospital, is completely isolated from John Doe at UCSF, even though they might be the same patient, right? They might have, flown from one side of the country to the other and had some sort of treatment. An application like Fasten, we don't do any sort of work trying to put those, link those records together, try to synthesize some sort of understanding. And I think that is the benefit of the kind of value that our customers kind of take on when they aggregate the data from all these different data sources. And we're ignoring all the data that's outside of the clinical sphere, right? We're talking about integration with payers. There's integrations with smart wearables and smart medical devices and just running information if you want, right? Like there's all these other kinds of data that can be synthesized together to give these incredible insights to patients.
Even financial data could be useful, right?
Yeah, so I don't think it makes sense for us or a Plaid in general to do, but there might be businesses that think differently, for sure.
I would strongly agree with that. I mean, I think what's telling is Plaid's origin is as a personal finance management tool, like a mint.com, and they struggled to use Yodlee and other aggregators that existed prior to Plaid. Plaid is the sexiest financial aggregator. It is not the first. It is not the only. There's plenty of competition. Teller and Yodlee and MX and a variety of others. But so they pivoted away from personal finance management because they said we need to solve the infrastructural problem. They pivoted away from the point solution, the application layer, and they haven't really gone back. The only thing you have is the ability as a consumer to log in and manage where your connections are, see when you've used Plaid, and maybe disconnect things. That's cool, and that's a good infrastructural way for infrastructure to surface themselves to consumers in what they play in this sort of space. What's even more interesting and telling is that if you look at the use cases on plaid.com, personal finance management is not one of them that is listed. It is lending, it is mortgages, it is crypto, it is the end consumers of embedded finance, where we don't say, oh, we're going to go put it into the nice little, the little box somewhere and then shovel it somewhere. Yeah. We're embedding it into the use case where they need it at the point in time they need it, because they are most motivated, the average consumer, to go through the full flow and convert at the highest rate when they need it for mortgage, when they need it for lending, when they need it for what else did they list here?
I mean, fraud was a big thing on IOC. There's a quote from Plaid CEO where fraud is number one discussion topics for banks and fintech, surpassing regulation. So banks, they don't like fraud.
Totally. And so if you think about it from that framing, the infrastructural capability is meant to service the use cases. And actually, Jason alluded to this. He said clinical trials. He said life insurance. Maybe he said life insurance, but I'm forgetting which ones you said. But like, these use cases are the embedded healthcare, where we start to put this capability into the non-provider facing scenarios potentially, that people need health data and they need it to make their lives easier to underwrite their life insurance or to participate in a clinical trial. That's where it becomes most impactful. That's where you see the highest conversion rate. I think we see that similar trend here that we saw with Plaid. And it does beg the question, why is Plaid so much more mature? Why is the banking industry have it figured out? Well, there's a lot more demand because Plaid can be used by almost any business in America when you think of it from a use case perspective. Everyone needs payments. And at its core, Plaid can help facilitate payments in an account-to-account fashion that is much more secure than the old way of typing over your account and routing number. Can the same be said for health data? It remains to be seen. Does every business in America potentially need health data? Maybe if you're saying that as an employer, they need it for managing their employees' healthcare, but I don't know that it's as an acute of a need. So there's a demand side signal here that drives why Plaid is more mature, is in that, for better or worse, there's more potential buyers for the infrastructural solution. That being said, I'm very bullish for Jason. I'm very bullish for Flexpo. I'm very bullish for this because there are a number of high leverage opportunities and use cases that, like we just mentioned, that really, really need it to improve onboarding for clinical trials or helping patients select the right Medicare plan or a variety of other things that just are untapped today.
I saw the demo you did, Jason, with Clear and the IAS use case, and that's huge. I know, Brandon, you posted that you were able to connect and go through that. And I feel that is an awesome accomplishment. So kudos to you on that. Do you feel like that's going to really grow and become one of the major use cases of what Fasten?
Yeah, well, I mean, so just fundamentally, the way that we view Fasten is that we're a turnkey solution for accessing medical records wherever they live, right? It shouldn't matter if if patients want to share their medical records via direct patient access APIs, or if they want to facilitate the collection of medical records directly from the TEFCA network via IAS, or if they want us to use eFaxes maybe down the line. But what we have done with the TEFCA IAS network, we are incredibly proud of the work we did there. It's been something that I've been trying to do for like 2 years. And the thing about the thing about TEFCA is the patient experience. When you start comparing that to this portal authentication mechanism, it's so incredibly clear that it is a much more patient-centric, a much more friendly mechanism for an individual to consent and share their medical records, right? All they essentially have to do is verify their identity using an ID verification platform like Clear or ID.me. So they take a photo of their face, take a photo of some government issue ID if the platform doesn't know who they are already. And then they basically click and specify which institutions they want to share their records from, because what we do with that verified identity is we actually federate a request out to the TEFCA network and say, hey, who knows about this John Doe that lives at this address with this birthday? And we get back a response of eventually probably a half dozen to a dozen different institutions that know about that individual. And then we give the patient the ability to say, yes, these are the institutions that I want to share with my personal health record app, with my clinical trial, with my care coordination company. That experience is fundamentally it's leaps and bounds better than having to say, all right, remember all the institutions you've been to, find them in a catalog that might actually be a subset of all the institutions that you actually visited. And then remember your username and password, log in, and then go through an experience. And we haven't talked about this, but every EHR actually controls the consent flow within, and it's going to differ significantly depending on the EHR that the hospital or health system uses. So Epic's consent flow versus Cerner's consent flow versus Athena versus Allscripts, they're all different. And in some cases, they're really friendly and they help the patient walk through that process. But in other cases, they give them big red exclamation signs or warnings saying, hey, there's an untrusted app that wants to access your data. Even though the patient wants to do this and they may be completely aware of what's going on, it can be a really scary and a very time-consuming process for them. And when you compare that to what you get with Tefka IS, like the rainbows and butterflies of what it could be.
It's dumb, right? Like it's, if you know the password and username of like your wife or your spouse or your grandma, you could technically pull all their health records, where I don't necessarily want my son like pulling down all of my records and then sharing them on like Roblox or something. But like they could, if they just see your password and username. Well, something like Clear, even with IAS, that would prevent that, because that's not who's the person accessing the. That's because you know the username. So there's a security equation there too.
There's definitely a security equation. I'll play a little bit of devil's advocate. It's more fun when we're not all agreeing. Like, I do think we need to think separately about the authentication layer and the authorization layer. And so if we think about IL2 as identity proofing and then to authenticating, and then you will, after that step, how do we choose to provision data back to an application is really important. And so authorization, I think people want that to disappear. I think that's still important because I don't necessarily want to share everything back to the app or trust that the app will take everything and only use the things that I say in the app. There's something to figure out and tease out there as we get deeper. Right now, I'm with Jason. When you let me do IAS, I was like, holy shit, this is everything we thought it would be. And so it needs to be scaled. It needs to be, everybody needs to get on the Tefka or equivalent, agnostic to the how, but right now it's working on Tefka. Nowhere else is it working. And it's get scaled. But then we do have to figure out those edge cases around authorization, those edge cases around caregivers and things like that. Like, how do we handle that? So we have things, there's still plenty of work to do, but authorization is really is an important step that needs to be considered. The scary app page, I want to put something out there that, like, there will be abuses of this. There will be abuses of this. And the more we reduce friction, we get rid of the scary app page, we let people just sort of sign up with any app that happens. As soon as abuses happen, then the networks or the legislators or regulators will pull back on what they've granted us, because this is an artificial construct that market forces would not allow. As we see with banking, as we started with, does not happen in a vacuum. JP Morgan Chase is charging the aggregators in banking in a vacuum. And that's what we would see here, in a vacuum. And so I am cautious of removing, if we go full board towards no friction and abuses happen, the pendulum will swing back, and it'll swing back harder than we want it to. So having a certification of apps or something, allowing the uncertified app and having the scary screen versus a certified app that has no scary screen seems smart to me, because then we can have clearer guidance for, as we scale this to less tech savvy, or people that could be elderly or whatever, that could be diluted by bad actors to connect their health data and have it be used maliciously. And so, like, that is it may be a small risk, but small risk with outsized outcomes means an expected value could be extremely negative and could lead to the whole house of cards falling down before we built it firmly with a firmer foundation. That's my pushback, in that I don't disagree that it's been weaponized, these screens, but there is something to it in the sense that the more we can inform and provide transparency about, good actors, the better we prevent against potential abuse, and that as we reduce friction, we increase the inevitable likelihood of abuse. With any exchange, there's inevitably at some point fraud and abuse. And so I don't want that future to come where we end up like banking.
So I wouldn't push back on that at all. I do agree that there is the potential for significant harm when it comes to the abuse, the misuse of a PHI, personal health, like private health information. But what I don't think is the right answer is for the EHRs themselves to be the ones determining if there should be a warning for an app or not. And I do not think they should be gating it behind, oh, have you paid a developer registration fee to be a known act?
I would think that would be illegal. It should be illegal, right? Other information blocking law. So yeah, totally agree there.
Yeah, but yeah, I completely agree. I think there is this potential now for the market to basically decide, hey, these are apps that are trusted and vetted, and their reviews, and use social proofs to basically determine which apps you want to use or not. And that comes back to your comment about authorization. As an individual, the way that I use apps is I basically give it, the minimum amount of information that's necessary for the app to function first, just to see what it does, how it uses the information. And if I don't trust it, I'll just delete it. But I should be able to then say, oh no, this is an app I like. This is an app that I trust. I've used it for years. All right, let me give it more consent. Let me give it access to more of my information because I think it's doing the right thing. And everyone around me that's also using the app has had good experiences with it, right? And there hasn't been any, violations or public articles written about how this app is doing things in a sketchy way. Agree with you completely. I think authorization is definitely a missing component when it comes to how TEFCA works. But I think that is something that we can solve after the fact. I think right now it's just this ability that we have to, access medical records via verified identity. It is just, it's night and day. Like it is such a fulfilling experience for patients.
That's my end of being contrarian just for the sake of the podcast. But
yeah, I have to sign up, Jason. Like, where do I sign up for that? No, I mean for IAS to try the IAS.
You can reach out to me. I think one of the things that we're doing with IAS at the moment is there's and I don't know how deep you want to go into TEFCA and IAS and the nuance there, but there's about 170 or so Epic sites that are live. I think there's 100 or so Meditech sites that are being added monthly. Cerner sites are not online yet, and they're going to be, Q1 of next year, where their QHIN is going to be online. Athena is really, I think, one of the few EHRs that are broadly available and responding on the network. And that means that for most individuals, you come in and start using Fasten, and you go, all right, well, I expect you to find 10 different health systems that I've visited and that I can remember recently. But when you actually go through the process, you verify your identity with a photo of your face and a copy of your government issue ID, and you get back one or nothing, you lose trust in the system. You don't gain it. And so
but that's one of the issues, right? Of having ability to we only have 180 sites, whatever, out of 500 or whatever, how many Epic installs are out there. But like not having somebody like Cerner is a pretty big part of the system, right? So cool. On authorization, I just wanted to add that I've recently had a conversation with, his name is Eyal. He actually is in Israel. There's an equivalent of a TEFCA, kind of like they have a 2027 law that was just passed. The authorization is part of that. In addition to the European health data space, that's in another legislation, and they're also looking at it from that. So you as a consumer of healthcare data services, basically you can authorize the different types of data that you want to share for different types of purposes. That is all written into these laws, which is interesting. It's not just like consent to everything or just log in and get all your data. It's like, no, you have to be able to segment by this is behavioral data, this is lab data, this is your, this, which I think is going to be huge.
I think 1% of patients or less will use it, just like GDPR. And so I think that is still worth doing. Granular consent is really important for a small percentage of patients, a small percentage of use cases. But like when you are on a EU webpage, how often are you like, it's either like, I'm not going to do any cookies or I'm going to do all the cookies, right? And so there's a small percentage of users that utilize that functionality. And from a societal investment, where do we put our energy? Is that where we want to do it? I think yes. I think consent, fine-grained consent is a really important enough problem for a small enough segment that is really, really, HIV, behavioral health, reproductive care, inmates. There's a lot of different use cases that it really does matter a lot. And so even if most people don't utilize those capabilities, it's noble and just to still pursue. But there's a real cost of building that level of infrastructure. It's really, really hard from a regulatory burden perspective on the servers and things to segment and chop up things that have been aggregated. And so I think that's one interesting nuance there. And the other is, where does that consent layer live? Is it a centralized service? Is really important, because if it's not, then you have a decentralized consent and you need to go and find all the consents that exist everywhere. That's hard. So we'll have to figure that out too as we get deeper into these niche, the next layer past TEFCA, base TEFCA IS of authorization, consent, caregivers, all those fun next level problems.
Yeah, I mean, another financial industry like Take is, authorized users. Like they let you add the authorized users to all your account. That's like built in how most health financial companies let you manage that data. And also, like, I'm also a manager on my wife's bunch of credit cards account, even though she's the credit card, because I'm just the one that like pays the credit card, whatever. So I think those are kind of like standard things that like we should think about as well in healthcare.
Yeah.
Okay.
I think is that the delegated access and proxy authorizations are pretty complicated because there's a lot of state by state level, decision making there. And then you also come against the wall of like, well, certain EHRs have implemented some of this functionality and others haven't. And so it's like from a technical level, there's just no global, this is the right way to do it yet. Yeah, so it gets really complicated.
That's how to make this FHIR related, or like FHIR technical related. Like there is an implementation guide in FHIR for consent flow and all that in proxy. So we're just like, as the industry catches up to like the standards, I think we'll see that as well, probably more built more and more on top of this. So, okay. Fascinating discussion. Thank you all. One last take is one bold prediction for 2027 that you guys can share.
I can go first. I think the CMS prior authorization rule, which is heavily based on Da Vinci, totally not what we're talking about in this one. Man, that's going to be a shit show. So get ready. That is due January 1st, 2027 for all payers to make available prior authorization APIs to providers, and payer-to-payer APIs for payers to, with consent, pull from other payers the prior claims history, sans adjudication or remittance details. Provider access APIs for providers to access claims details for their attributed populations, sans remittances. And then the patient access API gets an upgrade and gets additional prior authorization information. All that coming to you live January 1st, 2027, infinitely harder than the patient access APIs do, in 2021. Jason's connected to some of, Flex was connected to a lot of. That was easy mode. This is extra, ultra hard FHIR. This is CQL. This is Da Vinci. This is CDS hooks. Holy moly, that's going to be a fun little year for that if that stays on that target date. So that's I don't think it's that hot of a take, but I do think it's going to be a heck of a year in terms of FHIR expertise being needed if we continue down that path.
Okay, hot take. I don't necessarily think this is much of a hot take either, but I think we've been talking a lot about PHRs being, this central repository for all your medical records from all these different sources. What I'm actually seeing is that there's a lot of very niche, very community specific, chronic illness specific kind of applications. I don't believe there's going to be like a winner take all personal health record app. What I'm really seeing is that there's going to be these very, condition specific apps, or there's going to be, a very specific personalized medicine type of app that's going to solve a problem for a specific group of people. And they're going to take into account maybe the food that you're eating, plus your medical records, plus, your fitness routine. And then there might be a completely different app that's going to win in, a different kind of condition space. I think that is really, really interesting to me. I think that has it feels more real than the way that people discuss personal health record apps is kind of this one unified monolithic building block of an application. I don't see that. I think it's going to be a lot more nuanced, and it's going to be a lot more interesting for individuals. Yeah.
Virtualization is the name of the game. Yeah. Sounds like in healthcare because of the complexity and what you need to go through as a patient in a lot of these flows. All right, awesome. This has been a terrific conversation. Hopefully we can do it again with Joshua Kelly when he's recovered from his broken toe. And I also welcome anybody that listens to the show and wants to come on and talk shop and try to get us all to agree and disagree, provide spicy takes on all of these topics. Thank you so much, gentlemen. And Brendan, Please have a fantastic paternity leave time, and hope the baby's healthy and you're
Thanks
a significant
for
other.
that. And thank you for having me on.
Thank you.
Thank you.